much. It's very tough to put everything together in the 15 minutes, but partial extraction therapy versus a standard approach. What is the 21st century standard? I will show you the journey since 4 years and the last 2 megamind when I always focus on the partial extraction therapy, especially that I do it guided. So once we plan to extract the tooth, we should choose a treatment. So with high predictability of success outcome to meet the patient expectation and the low risk of complication. So it's this kind of motto which we should all know and we should think about it. So when we do something, especially in digital world, we can plan everything. We can plan when we extract and how we extract. Because the clinical relevance of dimensional bone and soft tissue alteration post-extraction aesthetic sites from Chavascos, we know after 8 weeks after extraction, we will lose 62% of the bone or 7.5 millimeters. It's a huge amount what we lose after we extract the tooth. So there are some strategies which we can implement in our daily practice to get the best result. From the evidence-based perspective, there are 4 strategies which we know there are valid to do it. So the first strategy is that what we actually didn't want to do nowadays is to extract and to wait. So we lose the volume, but we have to graft it with the GBR, we have to do soft tissue augmentation. Second one is extract graft with immediate implant placement, dual zone therapy from Professor Tanov, what we very good know. Third one is extract and graft with implant placement like veneer graft. So these techniques are well known for all of us. And the fourth one nowadays is a partial extraction therapy that should be considered as evidence-based. I will show you why, and why it is a fourth option, which for me is the first way to go. In aesthetic zone, from the premolars to the premolars in upper jaw, this is the best way to go for me with the results which I want to show you. So the guided partial extraction therapies, what I do in my daily practice in aesthetic zone if it's possible. So starting from the literature point of view, Howard Gluckman, we all know how he is the extraordinary dentist. What we know that after they have a retrospective study with almost 4 years follow-up, they have 96.1% of the success. It's a very good result, which you all know, because sometimes we lose the implants because it's the nature of the implantology. So another thing, from the Charles Schimmer, the very well-known studies, there's unplanned socket shield done. They remove it with the root. And what they did, they make a histology evaluation, and there is the clue of it, the clue of the success that we have between the implant and the root, we have the bone formation. So that's what we want. We want to have our implant in the native bone. We don't want to have in any augmentation materials which can lead to some kind of the complication in the future. So we want to have it a native bone. Another thing is, we know now what are the socket shield parameters. So there are 2 things that are non-negotiable and negotiable. So the C shape of the shield, line angel to angel, that requires to intact class 1 bone. Custom healing abduction of provisional crown, especially in aesthetic zone, is the standards nowadays. No mobility of the shield, create the S-curve for the future prosthetics, remove the apex and all of the RCT material, no periodontal diseases, no fracture of the shield. That is a must. What we can consider of some changes, and due to the different case selections, we have a fill the jump gap with the bone. We have to all take of care that it's not a xenograft, it should be autologous or allogenic bone if it's available in your country. Implant depth at the base of the S-curve, so we go deeper with the implant and we go with our shield a bit below. Avoid touching of the shield. It is possible, as I said, depends on the case selection. Shield preparation on the bone level or subcrestally. 2 millimeters of minimum shield thickness depends on the case too, and 2/3 of the buccal sheet should be remain. So my case for today is the gentleman who came to our office with the situation of the mobility of the central incisors, there is a frenulum with a spool effect. On the right lateral incisor, there was a tooth extraction, there's a breach. On the left one, we have the root canal treated teeth, so we decide to place 2 implants and make to the breach on the placement of the lateral incisors. And what we have to understand is how looks our position of the root in the bone and what we consider as a position of the implant. So in this case, first of all, I will always go with the first guide, because as my concept of the partial extraction guided, it considers of the 2 guides. So the first guide is the plan to remove the apex, to remove the all endodontic material, and to have the size of the shield as we want to have here. So we always plan to go around 1 millimeter above apex to remove everything what's possible. The second thing, after we knowing the anatomy, knowing the placement of the root, how it looks in the bone, we will know, thank you to the great group from Gluckman Ponte Institute, where we have to make our osteotomy, in which direction, because it's the thing which we sometimes forget, what the indication for the ostomy in which direction due to the depth placements of the root. So in this case, we have 2 implants. One is the native bone, and another one is placed more palatally, and there is a longer implant to gain primary stability. So, of course, before the surgery, my dental technicians prepare me the temporary bridge, which is a bit like a Maryland, because we have these hands which are basing on the teeth which we are leaving. So I have the best possible prosthetic position. It's not movable because the holes are bigger. We start with very easy extraction, removing the mobile teeth. We remove the coronal part of our prepared further socket shield place. We make the flap rise additional to the place how we plan the surgery. We did the socket shield preparation, so we leave the labial aspects, we remove it, everything is done guided. We place a second guide where we place our implants. So in this case, 2 implants, very easy, very good positions according to our prosthetic position, and of course the smart pack. So if you go immediate loading without ostel, there is no way that you will have a success, because you need a guidance. And the guidance is to use the ostel. It's non-invasive method, and after that we can check what is the value on the ostel. 74 ISQ, it's more than enough in this case, because it's a not single case, is a breach case, so we can have a lower value of the ostels. We have lots of data where we can do different kind of the loading protocol. In this case, we can very surely go with the immediate loading. Another part is, as is a breach, we cannot prepare it before that is curetane. We have to cement it intraorally. There is no precision at all that it's possible to do. So in this case, temporary abutments with the hex. Why with the hex? Because with the hex we have more engaging of the abutment to the implant. So we have a lower risk of the micro movement there, so we have a better stabilization. With suture, we deliver our temporary restoration. We leave the patient for around 6 months with it. After 6 months, we have removed our temporary. You did the intraoral scanning. We have a nice soft tissue outcome, especially the patient hasn't the best hygiene, but it's common to us. Not all people are taking care. We have a good volume of the tissue around the implants, and we deliver our final restoration. Our final restoration, this is the monolithic zirconia with the zero bone loss concept with the high polished surface from the soft tissue. This is how the patient looks in the mouth. This is the CBCT after 9 months. So here we have a presentation of our socket shield, which is present. Here we have the neighboring implant. And what is the best way to check how the tissue responds, how the bones responds? There are the studies which are showing about the facial contour preservation anterior immediate single tooth replacement with the socket shield versus connective tissue. They make the scans and they superimpose both of them and they check it. So actually with the intraoral scanner in our daily practice, we can easily do the same. So I check before the removing of the teeth, so in the day before the surgery, the first scan, versus the scan with the implant and how it's changed. What we have, so day of the surgery, it was 9.9, 21 millimeters, and now 6 months later, we have 9.63. So it's a minimal change of the contour. So we are sure that it should be as a standard because we are not losing it, and it is a minimal invasive procedure. So what are advantages and disadvantages of the partial extraction therapy? Because we have to take it as a concept, so to say, both sides. So advantage is the minimal resorption of the labial bone of the soft tissue, require less grafting and soft tissue at the time of the implantation, and minimize trauma in difficult extraction cases. What are the disadvantages? New technique must be learned by the doctor. It's a learning curve, which we all know. Root shield must remain stable during and after procedure. That's always we are praying during this procedure. Must educate the lab technician regarding subgingival space and contours for provisionals, abutments, and final restoration. So after the journey of many years, I have lots of cases which I present in the previous Megamind, where are the extraordinary results from the treatment. For me, the partial extraction therapy is a standard in aesthetic zone to achieve very good results and the stable results in the future. And to make it very comfortable for the patient. As I always want to treat my patients as I would treat myself. So there is always this thing that I don't want to make super traumatized procedure. I don't want to push the treatment for the very long time. There are the CBCTs from the cases. The average is 4 years of the implant placement. They are stable. There are no any issues with it. And there is a very, very good outcome result. For the home message, we have to think about that our primary objective is to achieve long-term aesthetic stability of both of hard and the soft tissue that we want as the implantologist, that we want to have the best outcome and the healthy tissue which will be the stable. But what is our secondary goals? I think this is the clue. The least number of the surgical intervention, reduce open flap procedure, the least pain and mobility for the patient, the shortest overall treatment and healing time, the most cost-effective treatment. In my daily practice, the partial extraction therapy, doing guided, fits to all of these goals that we can give our patients best outcome, shortest treatments of the time. In most cases, it's a one surgery only. It's not 12 months of treatment, and very stable results. Because the trick with the partial extraction therapy is that when we're leaving the part of the root, it's tricking our brain. There is a still root, so there is no bone resorption. So we are taking the advantages of losing it, of leaving it, and we have to know that nowadays it's really evidence-based technique, starting from 1967 when there was the idea of leaving the tooth under the dentures. So with all of the studies from Howard Gluckman, Nemetius group, we can safely say that is evidence-based, that we can consider it as a technique next to the techniques which we know since many, many years. Ladies and gentlemen, thank you for your kind attention, and try do it guided.